Hello everyone, my name is Mireia and today I will be presenting the paper titled Continuous Predictive Modeling of Clinical Notes and ICD Codes in Patient Health Records, which was accepted at the BioNLP workshop at ACL 2024. This is work that was done at Imperial College London with Clarence Ng and Dr. Marek Ray. I'll start by motivating our task. So, electronic health records are a rich source of patient information which includes their medical histories, treatments, outcomes, as well as many notes that were written during the hospital stay by nurses, doctors, and other technicians. The ICD codes refer to the International Classification of Diseases, and they are used to classify and code all the diagnoses and symptoms that were recorded during the hospital stay. Assigning ICD codes is a difficult task because the codes are highly technical and it requires a very intensive manual labor. Therefore, in recent years, there has been a lot of focus in developing computational approaches to automate ICD coding. However, current approaches focus on predicting the ICD codes using just the discharge summary document, which is a summary of the hospital stay that is written by clinicians at the end of the stay. In this work, we propose to investigate the potential of predicting ICD codes for the whole patient stay, even before they are officially assigned by clinicians. This is motivated by the fact that we have a large amount of data generated during various data points before the patient is discharged. So we wanted to explore the potential of using these earlier notes to predict the ICD codes before the patient is discharged. This could open up opportunities for predictive medicine, suggesting treatments and optimizing resource allocation during the hospital stay. For this reason, we propose the task of continuous ICD prediction, and to understand it, we need to look at the complete electronic health record sequence. This pie chart displays the percentage of notes in each category. So you can see that discharge summaries actually only comprise about 12% of the complete sequence, and that actually there are many notes which are generated throughout the hospital stay, such as nurse reports, radiology reports, or electrocardiograms, which provide real-time patient updates and which are currently not being used by most computational approaches to ICD coding. Therefore, we propose the novel task of predicting ICD codes throughout the hospital stay using the nodes available thus far. So, for example, to obtain the predictions in day 2, we would look at all the notes that were generated, such as nursing reports or electrocardiograms, during the first 2 days, and already attempt to make a prediction of the final ICD code. Before we move on to our approach, let's discuss some of the current models for ICD-9 coding and the background and history of this topic. All of these approaches for ICD coding typically use the MIMIC3 dataset, which provides a collection of electronic health records which are time-stamped free text reports written by nurses and doctors, as well as other notes, as I have mentioned before. And these are always paired with the final ICD codes that were assigned. Traditionally, models for ICD-9 coding would use word-to-vec embeddings and then apply the convolutional or recurrent approach. Transformers were initially actually unsuccessful in this task because of their 512 token limitation, which was there at the beginning. And this is because these clinical notes are actually very long. So the discharge summary has over 3,000 tokens, which meant that the typical transformer architecture was not suitable. Currently, some of the close to state-of-the-art models are long text transformers for ICD-9 coding. So we have some examples of efficient transformers, recurrent transformers, and hierarchical transformers which manage to overcome the limitation of the 512 tokens of current transformers. For our proposed task, we propose a custom model architecture which is tailored to this continuous prediction of ICD codes and uses causal attention to prevent attention to future nodes during training. Our model is called the label attentive hierarchical sequence transformer, and it involves various steps. So the input to the model is the full EHR sequence of all the nodes that were generated from the day of admission until the day of discharge. Each of these nodes is split into chunks of equal size t, which will be 512, and then the CLS embedding is taken as a representation of the entire chunk and is fed into a pre-trained transformer to obtain the chunk representations. Then we combine information among nodes by using a masked hierarchical transformer which applies causal attention. So at every time step, we are only allowed to pay attention to previous nodes to obtain the representation of the nodes at a given time point. So this masked self-attention is forbidding the attention to future chunks. Then finally, we apply multi-head attention between label queries and document embeddings. This is in line with most ICD coding models because the label space is very large. Typically, models only predict the 50 top ICD labels, and in order to do so, we use learnable label embeddings, and we obtain a different sequence representation for each label to ensure that we don't lose information and that we obtain the optimal embedding for predicting each disease. So in this case, we apply masked multi-head label attention, meaning that at each time point, we compute attention between all of the previous time steps and the label queries. Overall, this is the full architecture, which first splits the nodes into chunks and obtains the chunk representations through a pre-trained transformer encoder. Then we have a masked hierarchical transformer, which applies causal attention, and then we have a masked multi-head label attention, which applies also causal attention between the chunk, the intermediate representations and the label queries. Afterwards, we apply a projection layer and a sigmoid to obtain the probabilities for each day. And then this is trained using a binary cross-entropy loss. Even though we are using a hierarchical transformer architecture, which allows for us to extend the context beyond the typical 512 tokens, it still has memory overflow issues for our use case because we are tackling the complete EHR sequence. So the benefits of having a hierarchical transformer are actually not enough for such a long sequence. The main bottleneck of hierarchical transformers is that even though each chunk is encoded individually, therefore here we shouldn't have any memory issue, when doing backpropagation, the gradient must be backpropagated through all chunks, and this is causing memory overflow issues when we exceed for our setup and our GPU, it was when we exceeded the 16 chunks, but the full EHR sequence is around 56 chunks. So in order to mitigate this memory overflow, we propose a new way of training these hierarchical transformers, which we call the extended length algorithm, or ELA. The idea is that during inference, there is no backward pass, so the entire sequence can be used. Essentially, what we do is we transform the complete sequence of chunks of the input sequence into batches. And then we obtain the representations of each batch Then we concatenate them and we apply label attention on the complete sequence. However, during training, we need a way of allowing the model to see the complete sequence as well, because if we only trained, for example, on the last 16 chunks, but then during inference, we do this trick of batching the sequence and then concatenating and applying label attention on the complete sequence, the model would not have seen earlier nodes during training. Therefore, we hypothesize that it could be beneficial that during training, at each iteration, we apply random sampling to select just 16 chunks which can fit in our memory during training. So essentially what this is doing is generating different random augmentations of the EHR sequence, allowing the model to see the full sequence and having the added benefit of this data augmentation effect. So you see that at each iteration, we would backpropagate the gradient through different parts of the sequence. For our experiments, we compare our approach to similar models that exist for the traditional task of ICD coding using discharge summaries. And we have done the experiments of evaluating these baseline models on the new task. So evaluating their predictions on the 2-day time frame, the 5-day time frame, and the 13-day time frame. Essentially, the results at 2 days represent the performance of the model in predicting ICD codes using the nodes that are available up until 2 days since admission, and likewise for 5 days and 13 days. And these time points were selected because they are the quartiles, the first quartile, the second quartile, and the third quartile of our node distribution. So we have 25% of nodes within this 2-day time frame, 50% within the 5-day time frame, etc. We see that some codes can actually be predicted very early in the hospital stay. So we discovered that accurate predictions can be done within the first few days after admission. And in comparison with baseline models, we see that our model, the LAH-ST, exceeds the performance of the baselines in all timeframes before discharge. Next, we performed some ablation studies to analyze the effect of extending the context during training and inference. Here are the results of the ablation studies. So we compare the results of using our model with the extended context algorithm, which does some random augmentation during training and then uses the entire context during inference. And then we compare this to limiting the context during inference. So during inference, only using the last 16 chunks. And then we also compare it to limiting the context during training, so ablating the random augmentation during training. And we see that processing the entire sequence during training and inference with the extended context algorithm yields substantial performance improvements in all time steps. So it is an efficient way of handling these super long sequences of the electronic health records for predicting ICD codes at different time points during the hospital stay. Finally, we conducted some model interpretability studies to see where our model in the entire sequence was paying attention when making ICD code predictions at different time points during the hospital admission. We found that the label attention weights can be used to explain local predictions. So here is the attention map at 2 days, 5 days, 13 days, and in the last day. And you can see that before the discharge summary is available, the model pays attention to different nodes within the sequence, but as soon as the discharge summary is available on the last day, the model switches its attention completely to the discharge summary, as it is the strongest signal for predicting these codes. Then we analyzed how the attention was distributed across multiple document types. This is the attention map 2 days after admission, and this is and on the left we have the attention map 2 days after admission, and on the right we have the attention map on the last day. And what we see is that when the discharge summary is not available, the model has learned to pay attention to echographies, radiologies, and electrocardiograms, which are reports that are specifically generated with diagnostic aims. Therefore, it makes a lot of sense that these are the types of reports that the model is using to predict the ICD codes when the discharge summary is not available. But again, we see that on the last day, as soon as the discharge summary becomes available, the model is paying attention mostly to the discharge summary. So in conclusion, we introduced a new task related to ICD coding, which is the temporal prediction or the continuous prediction of ICD codes during the hospital stay. And we developed a custom model, the label attentive hierarchical sequence transformer model, which uses causal attention and an extended context algorithm to generate predictions at each time step and input a very, very long context of over 50 chunks of 512 tokens each. Our results show that ICD codes can actually be predicted as soon as 2 days after admission, achieving an 82.9% of AUG score just 2 days after admission, showing that these early nodes, or that the nodes generated during the hospital stay, also provide a valuable signal for prediction of ICD codes. And we also saw how our custom model outperformed the baseline models in all time points before hospital discharge. Thank you so much.